All right, so this is the second lecture of the 3 lectures covering the female reproductive tract. And in this lecture, we're going to be covering the uterus. So first with the uterus, it's a muscular organ. Serves as the site of implantation of the fertilized ovum. So just to review again, we have the oocyte, which is released during ovulation, and then it's swept into the fallopian tube by the fimbriae, and then here in the ampulla is where it's fertilized, where the oocyte is fertilized, and then it gets moved down via peristaltic contractions into the uterus, and then it undergoes implantation onto the uterine wall with inside. After implantation, the uterus subsequently expands to accommodate the growing fetus, so it's a very distensible organ. And then during birth, it provides the muscular contractions to help push the baby out through the vagina during delivery. Proximally, it's connected to the fallopian tubes and to the vagina distally. So here's where our connections are to the fallopian tubes on both sides. And then you have the vagina down here, which is the distal connection. It contains 4 parts, so it has a dome-shaped top here called the fundus, and this is analogous to the fundus in the bladder that we talked about in the previous lectures. So that's the top portion of the uterus. Then you have the body of the uterus, which is kind of the main part here. So the body of the uterus. And this is the part that's continuous with the lumen of the fallopian tube, so you can see that here. And then it's also continuous with the cervical lumen, which is in here. So the isthmus is considered the constricted part that connects the body of the uterus to the cervix. So we'll mark this here as the cervix, and then this section here, this kind of this narrowed section, is the isthmus. So fundus at the top, body is the majority of the uterus, and then you have the isthmus, which is this narrowing portion, which then connects to the cervix. And then the cervix is the inferior most part of the uterus, and it connects to the vagina. And now as for the parts of the body and the fundus of the uterus, so you have the perimetrium, which is the outer layer here, and it's a double-layered membrane consisting of thick connective tissue, and it's continuous with the peritoneum. And it's important to note that the peritoneum drapes down over the fundus of the uterus. Then you have the myometrium, which is kind of the bulk of the wall of the uterus. So this is the myometrium. Because again, remember, as we said, the uterus is a very muscular organ. So it has this very thick muscular layer in the center. And then the endometrium is this inner mucous membrane here, lining the lumen of the uterus. And this is where the zygote will implant during implantation to begin pregnancy. Some important ligaments. We've talked about some of these in previous lectures, just to go over again. The round ligament of the uterus, it extends from the uterus through the broad ligament, so it comes here, kind of where the junction of the ovarian ligament, and it goes through the broad ligament, and then it enters the inguinal canal through the deep inguinal ring, and then it exits out through the superficial inguinal ring to insert on the labia majora. And what it does is it helps maintain the anteverted position of the uterus, so kind of the anterior, kind of the way the uterus bending anterior, and we'll talk about that position in subsequent slides. Then you have the ovarian ligament, which is here, and that attaches the ovaries to the uterus directly, and that's just a connective tissue ligament. There's no arteries or veins or nervous structures within that ligament. And then you have the cardinal ligament, which is a pair of ligaments, and they're located at the base of the broad ligament, which is important, so down here. And what these do is they attach the cervix to the lateral pelvic wall. So they come out this way, and if you draw this line here as if the lateral pelvic wall, they kind of help anchor the base of the uterus or the cervix to the lateral pelvic wall. And these are actually what contain the uterine artery and the vein. So during a hysterectomy, which is removal of the uterus, this is ligated here because you want to ligate that uterine artery to prevent any kind of significant bleeding and easily remove the uterus. And we'll talk about that surgery in a subsequent slide as well. Just some more ligaments. So you have a uterosacral ligament, which extends from the uterus to the sacrum. So it'll come back here and attach on the sacrum back here. That helps just with stability and position of the uterus as well. You have the pubic cervical ligament, which extends from the posterior surface of the pubic symphysis. So you have the symphysis here, and then it extends from there to the cervix. So then you have the pubic, So then that ligament, it extends from the symphysis to the cervix here, and again helps with stability of the uterus. Then you have pubovesical ligament, which extends from the neck of the bladder here to the pubic symphysis. So you have a smaller ligament here from this neck of the bladder to the pubic symphysis. And these uterine ligaments and pelvic ligaments are actually, believe it or not, can show up from board exams on time to time. So it's definitely worth your time to be aware of what these ligaments are, what they attach to. And they're not too bad to memorize because it's usually just in the name. Now, the uterus can be in various anatomical positions, and the normal position is described as the following. So it's anteverted, which means it's rotated towards the anterior surface of the body. So here's our anterior surface of the body. Now, let's go through these lines here. Okay, so this is the axis of the vagina. So this red line here is the axis of the vagina. And then this blue line here is the axis of the cervix. Okay, and then this green line here is the axis of the uterus. Okay, or the body of the uterus, you could think of. Now, so what these terms describe is where the uterus has been positioned in relative to these various axes. So if it's anteverted, it's rotated forward towards the anterior surface of the body. So what does anteverted mean? It means that it's flexed in relation to the axis of the vagina. The uterus is flexed this way or rotated this way. In terms of anteflex, it's rotated it's in relation to the cervix. So anteverted is in relation to the vagina, and then anteflex is describing it in relation to the cervix. And so you have the axis of the cervix here, and again the uterus is flexed forward in relation to the axis of the cervix. So you have this green line here, and it's flexed forward or anterior in relation to this blue line, the axis of the cervix. Now, it's normally considered in this anteverted and anteflex position. Now, you can have the uterus where it's retroverted, which means that it's rotated back towards this way, rotated more anteriorly, rotated posteriorly in relation to the vagina. You can also, that can be in the normal position in some women. You can also have pathological processes that create that position as well. And then you can have retroflexed, where the uterus is more flexed this way posteriorly in relation to the axis of the cervix, versus where here it's in the anteflexed, it's flexed anteriorly. Now, the uterus during pregnancy, an important concept here is if we look at the superior view of the pelvis. So we have our uterus here, bladder's anterior, rectum and terminal GI tract here. So what was important to know here is when the uterus gets big during pregnancy, so if we kind of expand our uterus, since it's larger, it has the danger of pressing on the ureter. So here's the ureter here, and then the left ureter here, it's traveling here behind the GI tract. Now, it has more of a tendency to compress the right ureter versus the left. Now, why is that? It's because the rectum here provides a cushion for the ureter, so it's protecting the ureter from compression. And so, on this side, there's no GI tract or any other structure to help protect the ureter from compression by the enlarged uterus during pregnancy. So that's why the right ureter is more at risk for compression during pregnancy. Now, the neurovascular supply, main supply is the uterine artery, which is a branch of the anterior division of the internal iliac artery. And as you can see that here, it travels within that cardinal ligament of the uterus at the base of the broad ligament. So if we draw on here, if this is our broad ligament, and then down here at the bottom here is our cardinal ligament, which again goes out here to the lateral surface of the pelvis and helps anchor. So you have cardinal ligament, broad ligament running in the base here. Venous drainage is through the venous plexus within the broad ligament, and that drains into the uterine veins, which then go into the internal iliac veins. Lymph drainage is to the iliac, sacral, aortic, and inguinal lymph nodes, so uterine cancer would drain to those nodes. Sympathetic nerve fibers, they originate in the uterovaginal plexus, which is kind of a division or within the inferior hypogastric plexus, that main central hub of autonomic innervation in the pelvis. Parasympathetic nerves, they come from those pelvic splanchnic nerves, which have their cell bodies in the S2 through S4 spinal levels. All right, now that we've finished talking about the anatomy of the uterus, we're now going to talk about some relevant clinical pearls. Endometriosis, very common condition. It's usually in reproductive age women, women who are actively menstruating, so women in their 20s, 30s, even into their 40s. It's the presence of endometrial glands and stroma outside the uterine endometrium. So this is the key of the diagnosis. It's basically uterine mucosa or uterine tissue that's actively menstruating outside of the uterus. And now this tissue can be really anywhere within the pelvis or even in the abdomen. So you can have it up here in the peritoneum, you can have it here on the bowel, you can have it on the bladder, you can have it in the pouch of Douglas, which is kind of this region here. You could have it on the ovaries, fallopian tubes. Really, you can have this ectopic tissue anywhere. And it's believed to be caused by retrograde menstruation products that result in implantation of uterine tissue at an ectopic place. This tissue, again, it undergoes menstrual cycles, just like the normal endometrium. And it presents as very painful menstrual bleeding and pelvic pain. Now, it can have additional symptoms based on where the ectopic tissue is located anatomically. Now, so you can have, and when it's in the ovary, it's called a chocolate cyst. And it's, if you look at it pathologically, or if you were to surgically remove it, it's you see all this debris and tissue and necrosis, and it looks kind of blackish and liquefied, and so it looks kind of like chocolate. And these typically present as pelvic pain. It can be on the fallopian tubes here, and this can increase the risk of fertility because just like PID, pelvic inflammatory disease, it can cause inflammation in here and block the passage of the oocyte from the fallopian tubes into the uterus. And then it can also occur on those uterine ligaments, so those ligaments that kind of come out and help attach the uterus to the pelvic wall. You can also have ectopic tissue on those, and that can present as pelvic pain as well. Commonplace also is in the pouch of Douglas. So if we draw the peritoneum draping down here, pouch of Douglas or the recto-uterine pouch is in here. And so you can have endometrial tissue in here, so just behind the uterus and just located near the rectum. Now, as a result of its location near the rectum, the classic presentation is pain with defecation. You can also have it within the bladder wall. You can have ectopic tissue within the bladder wall. That again would present with pain with urination. You can have it in the bowel. You can have it in the rectum or any other parts of the bowel, even up into the abdomen. And these can create adhesions and then abdominal pain on presentation as well. Endometrial carcinoma. This is typically a cancer of older women, usually postmenopausal women. It usually presents with postmenopausal bleeding. And what it is it's a malignant proliferation of endometrial epithelium. It's usually due to increased estrogen stimulation on the surface of the endometrium, of the endometrial mucosa. That puts anyone that has increased estrogen exposure, especially a common tested question is PCOS, polycystic ovarian syndrome. Those patients, because they have increased androgen estrogen levels, they're at risk for endometrial cancer. Really, anytime a woman is postmenopausal and they present with vaginal bleeding, you definitely want to be considering uterine endometrial carcinoma and would definitely want to rule that out. Uterine prolapse. Now, this is when the pelvic floor, really the supporting structures of the uterus, either stretch or weaken. So that's the pelvic floor muscles that we talked about in the perineum lecture, or the uterine ligaments. Those stretch and weaken, and it results in the uterus essentially falling or sliding into, or even out of the vagina. So what happens is the uterus. Here's the uterus, and it'll slide, prolapse, or slide into the vagina, or it can even come all the way out. The uteral sacral ligaments are the most important at preventing prolapse, which makes sense because they anchor the uterus here onto the back of the sacrum here. So that's kind of a direct posterior anchoring here of the uterus. The most common cause is trauma during childbirth. That's the most common cause because childbirth really puts a lot of stress on the uterus, puts a lot of stress on the vagina, and really creates a situation where it's very easy for the uterus to then prolapse in as after the birth occurs. Some conservative treatment is due a series of exercises called the Kegel exercises, which involve strengthening these pelvic floor muscles to help prevent the uterus from easily prolapsing or sliding into the vagina. Then you could also do surgery. You could do a hysterectomy and just take it all out, or you could do a hysteropexy, which is where they go in and they surgically fix the uterus to an area in the pelvis or a structure in the pelvis to prevent it from sliding through. Really, these two options would probably depend on if the woman desires to have children in the future. If they don't want to have children in the future, then you could just do a hysterectomy. If they want to try and have subsequent pregnancies, then you could try a hysteropexy. Important clinical application as well with a kind of a hemostasis tie-in is that pregnant patients have an increased risk for thromboembolisms because of two reasons. One is because just the nature of pregnancy, the physiology of increased production of clotting factors. So that gives you a hypercoagulable state. So a pregnant patient is considered to be in a hypercoagulable state. And then what also you have is if you have the uterus here and it expands out into the abdomen during pregnancy, kind of especially during the middle and late trimester, you have compression of the IVC here. And so what that causes is it causes venous stasis and impairs venous return to the heart. And as a result of venous stasis, that also increases the risk of clot formation. That also decreases venous return to the heart, so you have decreased cardiac output. And then you can have, as a result, vasodilation peripherally. So the uterus, by this anatomical relation, really affects the cardiovascular physiology of pregnant patients. And as a result, it puts patients at an increased risk of thromboembolism, which is a very serious complication that would want to be avoided. So the hysterectomy, that's a surgical removal of the uterus. A hysterectomy does not include removing the fallopian tubes or the ovaries. Removing the fallopian tubes is, as we talked about in previous lectures, a salpingectomy. Removing the ovary is an oophorectomy. So typically, if the uterus is taken, you leave. You disconnect the fallopian tubes, and then you just leave both fallopian tubes and ovaries if there's no reason to take them out. Now, what's an indication for a hysterectomy? This is a very commonly done procedure by gynecological surgeons. Chronic pelvic pain, if their pain is refractory to medical management and they just can't take it anymore, you can consider taking the uterus out. Persistent vaginal bleeding that again is not amenable to medical therapy or other conservative measures. Gynecological cancers, obviously, you would want to take the uterus out. Intractable endometriosis, so the endometriosis has gotten so bad that this pain is so bad and it disrupts the patient's life that you would want to take it out. Also, if there's postpartum tissue that remains within the uterus that would put them at risk for infection or other complications, you would want to take the uterus out as well to prevent those complications. And then when the procedure is done, what you want to do is you want to ligate the uterine artery. So that's down here. And again, it runs in the base of the broad ligament, the cardinal ligament as well. And the big thing, so this is a posterior view. That's important to point out here, posterior view. And you can see the ureter having that spatial relationship to the uterine artery, which it dives under, that bridge over the water being the urine in the ureter. And it dives underneath that uterine artery. So again, when you're doing a hysterectomy, you want to be very careful when you're ligating the uterine artery to first isolate the ureter. And so that to help prevent any kind of accidental ligation of the ureter. Uterine fibroids, these are firm, typically benign tumors that occur within the uterus. They're comprised of fibrous connective tissue and then smooth muscle cells. They typically present with heavy or prolonged menstrual periods, abnormal vaginal bleeding, or pelvic pain. It could be any one of these symptoms or all of them, or any combination. The symptoms they depend on compression of adjacent structures. So these fibroids, they kind of form within the walls of the uterus. And if you have one in here where it's not really bothering any kind of adjacent structures, you may just have these symptoms here, the bleeding, especially with menstrual periods, pelvic pain. Now, the problem is when you get into where the fibroids occur in relation to other structures. So if you have one down here that forms, and these can get quite large. So if you get one that's really growing and pressing on the bladder here, then you're going to have increased urinary frequency or even incontinence due to bladder compression. So what you'd have is these symptoms coupled with, so you have the patient present with these symptoms here coupled with urinary frequency or urinary incontinence. Now, let's say you have one down here. it keeps expanding and expanding, and it presses on the rectum here. Again, you could have constipation, so you'd have these symptoms coupled with constipation. Now, you can also have one here in more the posterior aspect, and it compresses on the spinal nerves that are coming out of the spine here. And what that can create is kind of compression of the lumbar nerves and give you kind of back pain sensation. Or even if it got big enough and pressed on the sacral nerves, you could get even a sciatica type pain. All right, and that wraps up our discussion of the anatomy and clinical pearls of the uterus.